Hello and welcome to today's Center for Healthcare Strategies webinar, made possible by the Gordon Betty Moore Foundation on building the business case and value-based payment models for enhanced medication management. Before we get started, I'd like to quickly go over a few logistics. To eliminate background noise, phone lines are being muted during today's event. There will be 2 moderated question and answer sessions following the main presentations. You may submit a question online anytime by clicking the Q&A icon located at the bottom of your screen. Instructions are shown on the screen at this time. Today's event will be recorded and shared publicly on chcs.org. At the end of the webinar, we ask that you please complete a brief online evaluation that will pop up on your screen. Your feedback is very important to us, and we hope that you'll take a moment to do this. I'll now turn the webinar over to Caitlin Thomas-Henkel, Senior Program Officer at the Center for Healthcare Strategies.
Thanks so much, Travis. Welcome, everyone. We're pleased to have you join us for today's webinar, Building a Business Case and Value-Based Payment Models for Enhanced Medication Management. We have 2 excellent speakers with us today. Before we get started, I'd like to thank the Gordon and Betty Moore Foundation for their support of this project. And I'd like to introduce our 2 speakers. Randy McDonough is a co-owner of Towncrest Pharmacy and Towncrest Compounding Pharmacies in Iowa City and Towncrest Pharmacy in Saloon, Iowa. Dr. McDonough is also an adjunct clinical professor at the University of Iowa College of Pharmacy. At Towncrest, he is responsible for developing, implementing, and overseeing clinical services, managing staff, and marketing the business. He has helped to foster collaborative working relationships with several solo and group physician practices in areas such as immunizations, anticoagulation, disease state management, and medication therapy management services. He has also helped to develop and implement health screening and case management programs for private pay patients and self-insured employers. He was instrumental in implementing medication therapy management, MTM services, for the Iowa Medicaid Pharmaceutical Case Management Program. I'm pleased to welcome our other speaker, Amanda Brummel. Amanda serves as the Director of Clinical Ambulatory Pharmacy Services at Fairview Health System in Fairview, Minnesota. She is also an adjunct associate professor at the University of Minnesota. Fairview Health Services is an integrated healthcare organization that includes an academic health center, hospitals, clinics, retail pharmacies, and a health plan. Currently, Dr. Brummel has responsibility for the clinical development and integration of ambulatory pharmacy services in the Fairview Health System, including comprehensive medication management, transitions of care, and quality outcome measurement. The comprehensive medication management program consists of 35 pharmacies in 46 clinic locations. Next, I'd like to review today's agenda. First, I'll provide an overview of the Community Management of Medication Complexity Innovation Lab. Next, I'll turn it over to Randy McDonough to present his slides on making the business case for enhanced medication management services, followed up by a question and answer period. Then we will turn things over to Amanda Brummel, where she will give her presentation on comprehensive medication management services at Fairview, creating the business case. And we will close with a moderated question and answer with Dr. Brummel. First, I'd like to provide a little bit of background about the Center for Healthcare Strategies. CHCS is a nonprofit health policy resource center dedicated to improving the health of low-income Americans. We have 3 main priority areas: integrating services for people with complex needs, building Medicaid and cross-sector leadership capacity, and advancing delivery system and payment reform. And we support health plans, providers, and health systems through knowledge development, collaborative learning, technical assistance, and best practice dissemination. This infographic represents what medication complexity looks like and some of the community-based strategies that are underway through the CMMC Innovation Lab. For instance, at the top, as you can see, Close to 1 million ED visits are attributed to medication complexity. Risks of medication complexity include adverse drug events, failure to accomplish treatment goals, and drug interactions. At the bottom, you can see several different strategies that are outlined to address these issues. They include strategies such as identifying people that are most at risk for medication complexity, segmenting the population, using risk algorithms to identify people and titrate the interventions to match, simplifying medication regimens, deploying various non-traditional health workers such as community health workers, pharmacy technicians, and others, and empowering patients so that they have the ability to manage their complex medication regimens to improve their health outcomes and patient satisfaction. Here are a few goals of the Community Management of Medication Complexity Innovation Lab. This is a 2-year initiative funded by the Moore Foundation that's supporting 5 providers as they test and implement various community-based interventions. The goals include identifying and advancing effective community-based strategies to address medication complexity. The second is to support opportunities to further refine, spread, and scale promising strategies to other settings. And last, but probably most important, to improve patient experience, empower individuals with complex medical, behavioral health, and social needs so that they can effectively manage their medication regimens. Next, a little bit of an overview about the sites that are participating, 2 of which are with us today presenting. First, Northwestern University is partnering with Health Lab to implement the Universal Medication Schedule. Next, Pharmacy Society of Wisconsin is providing training to pharmacies to implement CMRs and final product verification using trained pharmacy technicians to dispense medications and free up pharmacists. Care is partnering with community pharmacies to implement a medication risk score within the EMR and deploying multidisciplinary care teams. Towncrest, who's with us today, they're using prescription claims and assessing patients' social determinants of health needs to identify and intervene with high-risk patients. And finally, University of Minnesota is partnering with Fairview Health Services, who is with us today, providing comprehensive medication management to behavioral health patients and understanding their social determinant needs that are mapped to medication therapy problems to further optimize medications and prevent readmissions. Next, I'm pleased to turn it over to Randy McDonough.
Thanks, Caitlin, and I appreciate the opportunity to present at this webinar today. And my particular presentation is about making the business case for enhanced medication management strategies. There are several objectives with this presentation, and so you can read through those. But really, I want to talk about the transformation of community pharmacy and some of the work that we've done with value-based reimbursement, in particular with a pilot study that was done with Wellmark, which is our biggest payer in the state of Iowa. You know, as I've been an owner now for the last 13 years, I've seen a lot of changes happening in pharmacy, and it doesn't seem that a day doesn't go by when there's a news story about the cost of drugs and what we need to do to reduce the cost. And because of that, there's a lot of downward pressure on reducing the reimbursement for a product. And also we're seeing in community pharmacy DIR fees, which is direct and indirect remuneration, which is really more supposed to be a pass-through of a rebate from the manufacturer onto the ultimate payer. And then pharmacies are the ones that are getting this retroactively put on, that they have to pay for that. So we're seeing reductions in reimbursement, and we have these DIR fees for which it's hard to plan on our bottom line when we're not exactly sure how much we're going to be assessed for some of those fees. Plus there's this market consolidation. We're seeing bigger players. We're seeing vertical integration. We're seeing PBMs consolidate with one another. And what this is causing us is a disruption with how we're looking at our practice, because we realize there's a disruption happening within the marketplace. And it's causing us to say, what do we need to do to transform our practice so that it's not product distribution, but it really is patient care and making interventions and working collaboratively with other healthcare providers. But it's also looking at how do we get reimbursed. And obviously there's still the product component of that, but as I said, the downward pressure on reducing the cost of products is happening. And if you're just a dispensing pharmacy, not really looking at patient care services, you're probably not surviving. And we've seen a reduction in the number of independent community pharmacies in the state of Iowa, and I know that that's true nationwide. So really those pharmacies that are surviving have looked at other ways that they can bring in revenue, which includes providing clinical services, but also working with other providers and with health systems and with ACOs and plans to develop a new reimbursement system based upon the value of the care that they provide, or value-based reimbursement. The challenge as we move into this value-based reimbursement, and as we have to transform our practice, and this is not just happening to pharmacy and community pharmacy, this is happening for all providers as we move into a different type of reimbursement for healthcare. But it's not easy to do this, and there's a lot of cost associated with it, and a lot of time and effort that you have to bring to transform your practice. And it requires a lot of commitment from the owner perspective, but a commitment from all the staff, persistence, and as I said, a lot of investment of money and time. The problem that we're running into is as we move into this value-based reimbursement, we're seeing this decline in reimbursement on the product side at a much faster rate than we're seeing the reimbursement on the service side and on the quality side. And that value-based reimbursement has not matured to a point where it's offsetting, the loss that we're seeing on the product side, which is making it very challenging for the pharmacies, to survive in this new world. So it requires you to really diversify and look at other opportunities to help you survive as you evolve your system. Part of the transformation is transforming what pharmacists do. As I said, no longer just the dispensing function, and we've got technician and also technology that can take care of the dispensing functions for us. But what are the pharmacists doing within those community pharmacies? And I used to promote, when I was a professor at the College of Pharmacy, that all community pharmacists, all pharmacists, but community pharmacists need to be interventionists. They need to identify and resolve drug therapy problems, working collaboratively with other healthcare providers, sending clinical recommendations, and documenting their patient workups. So having a good, robust documentation system. Plus, it's difficult because the acceptance of this new model is not necessarily there. So as community pharmacists start providing these kind of interventions and make recommendations, it may be something that health systems or provider offices may not recognize it or may not accept it. So there's an evolution of the acceptance of the community pharmacists providing these new services. So I've seen it all in the 13 years that I've been an owner at Towncrest Pharmacy. Well, it requires us to change the business model for how we are practicing in community pharmacy. And so, as I said, it's moving from the fee for service, no longer just the product distribution and getting paid for product, but really looking at how we can fit into this value-based reimbursement model and how we can fit in working collaboratively with other healthcare systems and health plans and ACOs and other providers, and how do we become part of that team approach, and then how do we share within the revenues from that perspective as well too. So this does require us to form new relationships with payers, but also forming new relationships with providers as well. So what we've done at Towncrest Pharmacy is we made a commitment a number of years ago, and I left the University of Iowa College of Pharmacy as a full professor, and I left 13 years ago because I wanted to prove that you can provide clinical services within community pharmacy. So early on, we made the decision that, we really have to ensure that when we have the patient encounter, that we're optimizing that patient encounter. And so we trademarked a term called make every encounter count, which all that means is when that patient's in front of you, what are you doing to assess them to make a decision if their medication is being optimized appropriately? Have they reached a therapeutic outcome? Is their medication safe and effective? So we created a process that we called COMM, C-O-M-M, or continuous medication monitoring, for what the pharmacist does during that time that they're with the patient. And then how do they actually do this on the run, do this in a very busy pharmacy, and document their activities as well too. So it requires certain strategies within the pharmacy, which includes medication synchronization and optimizing that so that you're more efficient with the dispensing of medications. but also you're doing other things such as optimizing technicians and using automation as well too. It also requires us to, for a certain group of our patients, who are more of the higher risk patients, that we're doing regular comprehensive medication reviews, or we're doing more of a case management approach for those high risk patients, because that's the patient group that's going to be the most costly to the system. So how can we do these medication reviews, send that information and recommendations to the other providers, and try to close that loop of communication between multiple providers who are trying to manage this patient in an optimal way? We actually have published information about continuous medication monitoring, but again, what is COM? It's something that happens in real time. So it's teaching the pharmacists how to transform their practice so pharmacists are freed up. We want the pharmacists freed up to provide clinical services to the patient. So they're focused on the patient's medications, and they're identifying actual or potential drug therapy problems, or collecting further information to determine if they actually do have a problem. If it's determined they do have a medication-related problem, then making actual clinical intervention to resolve that problem, sending that information on to the prescriber, and making sure, again, we're documenting that information and just closing the loop between the documentation, or between the communication between the different providers. I've alluded to that one of the things we have to do to optimize the practice and optimize the pharmacist time, or free up the pharmacist, is to use medication synchronization. So that's one aspect. And with us, we have a patient population of about 2,500 to 3,000 patients, and about 1,400 to 1,500. So almost half of the patients that we actually manage are synced up in some way, whether it be through on-time refills, or actually using some kind of compliance packaging for them. But we have about half of our patients that are synced up in some way, which really improves our efficiencies from that perspective. Plus, you can utilize your technicians in a much better way, and also use automation from a filling perspective to free up the pharmacist to provide patient care services. We have moved from having no robots within our practice to having 4 robots within our practice, again, to improve the efficiencies of the dispensing function, so the pharmacists are freed up to focus more on patient care services. The thing that's probably the most controversial for our practice is that we moved away from the stripped down model of community pharmacy practice. And what I mean by that is it's not a skeleton crew. I don't just have one technician, one pharmacist on staff. At any one time, I can have anywhere between 3 to 5 pharmacists on staff. All of them are busy, and all of them are doing patient workups and communicating and intervening and documenting their activities. We make between 2,000 to 3,000 clinical interventions monthly, collectively, as a group at our 2 practices. Plus, we developed our own clinical documentation system so that we can actually document the activities and take credit for the services that we're providing. The other thing that we've done uniquely to our practice that we're trying to teach some of the other community pharmacists out there is, how do you actually stratify your patient population? Because you got to be as efficient with your time as you possibly can. So we believe that if we can stratify our patient population, then we can identify what are those services that we can provide to manage those patients optimally. For all patients at that baseline, we provide continuous medication monitoring services. So for the low-risk patients, they're receiving that continuous medication monitoring service, and then the pharmacist is trying to optimize those medications. For that medium-risk patient who may have a couple of chronic conditions and taking 3 or 4 chronic oral medications or injectables, what are we doing to try to manage that disease state better? Are we doing a cardiovascular risk assessment? Are we doing a fall risk? Are we determining, do they need to be on long-term PPI therapy? Do we have some type of targeted intervention that we can do with this patient population to optimize them? With the highest risk group being the most costly, it's about 20% of our population, but that's also the group that we're spending the most time with to try to manage them most appropriately to provide these more comprehensive services. This also requires to change the expectations of patients, because if they're just used to going into a pharmacy and receiving a prescription, but not really having a pharmacist asking a lot of questions beyond just the counseling of a new medication, but actually digging into their past medical history to try to understand, you know, how their drugs are working and are they actually reaching a therapeutic outcome. So it does require kind of a change and how the patient perceives of what you're doing and what they expect that you're going to do for them. And it's not just on the patient side, but also on the prescriber side of the other provider's perspective as well too. So our job is to assess the patient's clinical information, identify the related problems, make our interventions, communicate with the patients and providers, and then document our actions. On this slide, you can see some of the clinical documentation that we're doing. This is the system that we created, but we need to be interventionists. We need to actively identify and resolve drug therapy problems and making sure we're communicating that information to all the providers to make sure the patient is being optimized with their medications. So we make these clinical recommendations on a regular basis and document those patient care activities. But we also have to be aware about what are those metrics that payers are interested in, because obviously we got to make sure that we're identifying those metrics that are of value from a payer perspective. And so what we've learned working with some of the payer communities that we have been working with is total cost of care as a driver. They want to see if the interventions that you make is reducing overall cost of care, whether that be reducing in hospitalizations or reducing clinic visits or reducing hospitalizations or ED visits. They want to see that something happened that you reduce that. Plus they want to see, are you affecting outcome metrics, clinical metrics such as A1Cs and lipids, blood pressures, but also are you affecting certain medication metrics such as, are they on the right statin intensity dose? Are they reducing the number of high-risk medications that they're taking? So those are the kind of metrics that we're trying to affect on a regular basis, again, by providing continuous medication monitoring services, but also working collaboratively with other providers. As our case example, at Towncrest Pharmacy is where I have our practice. And there's 5 areas of Towncrest Pharmacy that I tell people that, you know, these are 5 distinct areas. They work in collaboration with one another, but each area has got to be financially viable on its own. That includes our dispensing area for our ambulatory independent patients, includes our nursing home patients. We got our clinical services area, we got our compounding, we have our durable medical equipment. These are all the services that we provide at Towncrest Pharmacy. And what I would tell you is, if you look at this list, there are certain services that are actually highlighted or bolded. That's because we're part of a network of high-performing pharmacies called the Community Pharmacy Enhanced Services Network, and we have a CPSN Iowa network, of which we have 104 members, pharmacies, part of this network. And these are the required or the core services that all of our network pharmacies will provide. So as we're going to payers and working with providers or health systems, we can guarantee them that all 104 pharmacies will provide these kind of services to, again, to try to optimize the patient's medications. What we did a number of years ago, and it was back in 2013, is we challenged one of the payers in the state to look at community pharmacy differently. And it came about because we were seeing a tremendous reduction in the amount of reimbursement we were receiving on the product side. And we were even seeing some of the products were getting reimbursed quite a bit less. And in one particular case, we had one patient that I had helped to titrate on to clomipramine for OCD, and the drug went up by 8,000%, but I was still paid as if it was costing me less money. So I was losing $700 on every refill. So after going through all the proper procedures to let the PBM know what was happening, we still got the same type of reimbursement. The following month, I still lost another $700. So I actually sent a letter to the CEO of Walmart explaining that, you know, you need to look at community pharmacy differently, because with the reductions in reimbursement on the product side, below our cost even, we're not going to survive. So what can we do to demonstrate to you the value that we can provide? And that's how we came up with this project, this pilot, which ran for a full year, for 12 months. The analysis was actually conducted by Wellmark's analytic group, and there's 3 groups of patients that they want to actually study. One group of patients actually came to Towncrest Pharmacy 100% of the time, so they're 100% attributed to us. Group 2 were those patients that were shoppers, so they came to us 50% of the time, but the other 50% of the time they were going to other pharmacies. And then group 3 were those patients who never came to Towncrest, so they were 0 attributed to us. So what they wanted to find out is, was there a difference between total cost of care, and was there a difference between the clinical metrics between those 3 groups of patients? The outcomes of interest that they were looking at from a clinical perspective include medication adherence, which they used proportion of days covered, or PDC. They looked at medication persistency, so they wanted to see if there's any gaps between refills. They also wanted to look at use of high-risk medications, again, using the Beers criteria. And last, probably the biggest driver of this project, though, was the total cost of care. How did we affect the total cost of care for that payer? So after 12 months, we looked at the data. Now, I was getting these data draws quarterly, so I kind of had an idea about what was going on, but after the first quarter, I was hesitant about saying anything until we can let all the data run out. But it was looking promising after the first quarter. But after the full year, when they looked at the three groups, they saw that between group 1, which is again the group that's 100% attributed to Towncrest Pharmacy, and group 3, which is they're not 0% attributed to us, there was a reduction and per member per month cost of care of $298. So those patients who came to Towncrest Pharmacy 100% of the time had almost a $300 less per member per month cost to the payer. Then when they looked at the next group, which is again group 1, which is those patients 100% attributed to us, and group 2, which are those patients who shop, they actually did see that shoppers who are going to multiple pharmacies actually do cost more from at least this study perspective. And here they saw that was about $309 lower per member per month cost for those patients who came to Towncrest Pharmacy as compared to those who shopped. So the summary from the pilot showed that for those groups that were matched for age, gender, risk category, and utilization, the total healthcare costs were much lower for the 100% Towncrest group. And what they assumed from this is that the differences were likely due to a combination of unmatched patient factors, provider effects, and also Towncrest Pharmacy. So it's not a randomized clinical trial. We downplayed that this is a cause and effect study. But it was interesting to see this dynamic of those patients coming to us, and the more they came to us, the lower the costs they were associated with. But we also saw with the pilot that regular high-quality pharmacist care and pharmacists making interventions was associated with better outcomes. And again, as I talked about the stripped-down model of community pharmacy, stripped-down model is not how we're going to have these outcomes. It really requires the practice to transform their practice, free up the pharmacists, have sufficient staff so pharmacists can be interventionists and identifying and resolving drug therapy problems. We did publish this work, and was published over a year ago. And what's interesting, this actual study was identified as best clinical paper that will receive this award this month at the APHA annual meeting. But this pilot study did demonstrate that members attributed to Towncrest Pharmacy had better clinical outcomes and lower healthcare costs. And it demonstrated, at least for this particular pharmacy and with this particular group of patients, that community pharmacists can impact patients' therapeutic outcomes by ensuring that patients are on safe and effective medications. What are some of the next steps that we're seeing with Towncrest Pharmacy? One is we started working more collaboratively with one of the health systems in town, which is the University of Iowa hospitals and clinics. We were one of several sites within the country that started having the community pharmacists work with pharmacists embedded within clinics. And when we started doing that and sharing information through a secure portal system, we were able to identify that there was a lot of information that we had that the clinic didn't have, and there's a lot of information the clinic had that we didn't have. And once we started sharing that information, we started seeing that there were some issues the patients were having that neither party was aware of because we didn't have all the information. And by sharing that information, we were able to optimize the patient's medications better. We're also in current discussions with Mercy in Iowa City and working with them in their ACO to see how Towncrest Pharmacy can be integrated within some of their physician practices to provide some of these services that we were able to demonstrate with the Wellmark project. The Wellmark pilot evolved into a value-based pharmacy program. There's 74 pharmacies that are now enrolled in the program. They are paid a bonus incentive if they reach certain metrics, which include total cost of care and these clinical metrics. If they don't hit the metrics that they're supposed to, they don't get reimbursed this bonus. If they do hit it, depending upon how well they hit it, there will be gradations of how much you can get reimbursed, up to $6 per member per month. We also created, as I said, our own high-performance network called CPS in Iowa. We have another contract beyond just the Wellmark, the Blues of Iowa. We have an enhanced MTM contract with the Blues out of Minnesota. And in 2018, 78 pharmacies providing almost 2,000 medication therapy management services received close to $500,000 in reimbursement for providing these services and reducing overall costs to that payer for providing enhanced medication services. We're currently having discussions with other MCOs and with Iowa Medicaid and other employer groups within the state, trying to show them the value that we can provide as a high-performing pharmacy. So the lessons that we've learned is that pharmacists, especially those in the community pharmacy, need to really transform their practice. They need to transform how they look at their practice and actually how they perform their services. They need to free up the pharmacist to provide clinical services, and it's all about optimizing the patient's medications and impacting metrics, both the clinical metrics, but also cost of care. It's also extremely important that we're collaborating with other providers, and that includes our pharmacist colleagues who are in health systems, because we are finding out that by communicating with those pharmacists, whether it be transitions of care or, as I said, with those clinical pharmacists embedded in clinics, we have a much better outcome when we're working together that way. As I said, pharmacists, especially community pharmacists, need to be interventionists, identifying, resolving drug therapy problems, and being part of a high-performance network helps to secure contracts with payers because you have better coverage of the state and of their lives by having a group of pharmacies versus just one or two pharmacies.
Randy, thank you so much for that excellent presentation. The questions are rolling in, but just a reminder, to submit a question online, please click the Q&A icon at the bottom of your screen. So we have a few questions. The first one, Randy, is how long was the pilot study? And if you can recall this, it's a kind of top of mind question. How many adverse events happened in each group?
The study lasted for a total of 12 months. As far as the number of adverse events, they did not look at that. As I said, they focused their measurement on the metrics, and it was persistence, adherence, and also high-risk medications. But with that being said, we can tell you that from our perspective, we kept our own study as well too, and so that's been published as well. We made, during that time, about 17,000 clinical interventions, and 50% of those interventions had to do with a drug therapy problem. As you start digging out what those drug therapy problems were, the most common was need for additional therapy. And then the next was need, to adjust the dose in some way. Adverse events and drug interactions are not as frequent as we think they are sometimes, as far as optimizing the patient's medication. So that was from our own internal study, but I can't compare that to the other two groups that we didn't have access to those records.
Thanks, Randy. Appreciate those insights. Next up, someone has a question related to scope of practice. Did you face any scope of practice issues before implementing this project?
Oh yeah, I've got battle scars to demonstrate, some of the scope of practice issues. But whenever it's been, and in fact, I'll be honest, earlier on in my career, I've been submitted before the Board of Medicine and Dietary Board for the claim of practicing outside the scope of my practice. But whenever it's been investigated, it didn't demonstrate anything beyond me just being a very engaged and good pharmacist. Because my focus is really, I don't make changes of therapy, without the doctor giving me the approval. Everything that we do is focused on optimizing the patient's medication, working collaboratively with other providers, and sending our recommendations to them on a regular basis. It's more the acceptance of this more engaged role. I think that's been some of the issue. But to be honest, that's gone, that has not as bad as it used to be. We get about a 90 to 95% response rate for all the clinical interventions that we send. We get it in real time, usually within the same day. And as I said, now we've got, health systems that have approached us and ACOs that have approached us asking how they can work with us. So, we've gotten through some of those early days when, that was so new, people didn't really understand what was going on. But as far as scope of practice issues, we follow it to the T as far as what we can do, what we can't do. And then we do have collaborative practice agreements for certain programs such as immunizations. And we like to explore, expanding on that as well too.
Great, thanks so much, Randy. We have a question. Would this type of model require more pharmacists to do more in their clinical residencies to provide these services?
Yes, that's a good question. And we are a residency site, and I have trained close to 25 to 30 residents in community pharmacy residencies. And at Towncrest, probably about 15 of those residents I've trained, because the other ones were when I was at the university and I had a practice site in Davenport, Iowa. But so yeah, and what we teach those residents is the importance of them collaborating, the importance of them making good clinical recommendations, and doing this on a more regular and consistent basis. Make sure they're evidence-based. And so when they make a recommendation, that they're confident about that recommendation, because I'm like, you don't get second chances if you're making these kind of recommendations. So you want to demonstrate your value, you want to demonstrate your knowledge, and the prescribers and other providers have got to trust you. And the only way they're going to be able to trust you is that they are confident in your competence. And the way they're going to be confident in your competence, they can see firsthand the type of interventions that you're making. So we have as I said, we have a good relationship with a lot of physician practices in town. And when I go in and talk to them and ask them, do you see these recommendations being made by other community pharmacies? They say no, to be honest. So what I want to do is increase the number of community pharmacists who are doing these kind of services at a high level, at a good quality level. Again, with our high performance network, I'm working with about 9 of these practices within the state to help transform their practices so they can provide similar type of services.
Thanks, Randy. We have a question now about how are patients risk stratified for inclusion in the study and for your current VBP arrangement?
Yeah, that's a very good question. What I didn't know when we started this is just how much data a payer has in regards to their patient population, and I realized they had a whole risk stratification score for their patients. And in this particular situation, the patients were risk stratified by 9 groups. And what we did is looked at those 9 groups, and then we took their stratification and further stratified it into them low, medium, and high risk. So groups 1 through 4, as we started digging into the kind of issues that they had, we realized they were a very low cost group to that payer. And so we felt like if we can just do good pharmacy services at the time that they're coming in to get the prescriptions filled, then we should be able to manage them appropriately and keep them from moving up to a medium risk or high risk. And then groups 5 and 6 were the targeted ones. So these were individuals who were emerging into potentially becoming high risk individuals. So with these individuals, we were doing targeted interventions. And so if they are taking a statin therapy or on the right statin intensity, so we do a 10-year cardiovascular risk assessment. If we got an older patient that we're concerned about falls and they're taking some high-risk medications, doing a fall risk assessment, providing that information, sending it on to the prescriber and making recommendations to them. And then with that very high-risk group, which is groups 7 through 9, these are just costly. I'm not going to modify their risk anymore. What I'm trying to do is manage the best that I can so they're not utilizing a lot of healthcare resources, trying to keep them out of the hospital, especially from a medication perspective. So what can I do to case manage these patients to ensure they're reaching the outcome the best that they can and reduce any type of adverse event and reduce any type of health event that they might have, so we can keep them as healthy as possible. So they get a lot of intensive services from us, right? Because we're trying to make sure we're optimizing the best that we can. So that's how that group has been stratified. And it's a very similar stratification for the value-based pharmacy program as well.
Excellent. Thank you for those insights. We have a question about how do you still manage to do the day-to-day, Randy? Dispensing meds. I know you talked a bit about automation and some of the other things you do, but how do you still continue to do the core pharmacy services and then add all these enhanced services on top of those responsibilities.
Yeah, well, if we go back to what I talked about, what are those components of practice that you need to change and transform? One is, improve your efficiency. So as I said, we have most of our patients, at least half of our patients synced up. So that improves your efficiencies, also improves your inventory control. Plus, we integrated the automation. We are a technician-driven dispensing pharmacy, and in the state of Iowa, we're still studying the new practice model. They're supposed to be writing up the administrative rules on that, but where the technicians can do the final verification, so tech check tech. That's another strategy that we can use to free up the pharmacist. And so using all those strategies that free up the pharmacist, but the last thing that I think people don't understand is we made an investment in our people. And so I took a staff of between two pharmacies, and it was 12 people when I started in 2006. And now we're at a staff level of 33 employees. And so a lot of that has been pharmacists and technicians. And so we had to come up with new strategies of making new revenue because that's a higher payroll. But we were able to successfully do that with the services that we provide and with some of the contracts we've been able to secure. And as long as we can continue to evolve that, I think we're going to be fine. But I don't rest on my laurels because I realize that you got to keep proving yourself and demonstrating the value so you can continue to go to payers and secure these value-based pharmacy contracts.
Great, thank you. We have a lot of questions about the data. I'll ask the first one. There's three. When you receive a new patient referral, what was your process in obtaining the initial orders from various providers, and how did you go about syncing their meds?
Yeah, so the syncing the meds has been an evolution for us. So we'll start there because that's how you can improve that. But you're syncing up their meds by looking at when they're getting all their refills, and then identifying what's a common fill and looking at the most costly medication and saying that's the one that we want to make sure we focus in on initially, so that they're not paying like a double copay on a name brand medication. But once we got them synced up and getting the patient to understand the value of the sync, then it just kind of runs on its own. So it really evolved very, very quickly from us from that perspective. As far as the patients, and what was interesting about that is there was 600 individuals that were part of this pilot, and these were already patients that were within our system. So we already had them. So we had a lot of information because we had been providing these services for a long period of time. So we request information, to be honest. So if we have a patient that is new to us, or a patient that we know has been hospitalized or has had a transitions of care, we will request that information, and we have a good relationship with health systems and the providers in town that we usually get that information. We don't have access to electronic health records across the board. We have it for certain patient populations, which includes hospice patients through Care Anywhere, and also for some of our nursing home patients utilizing Matrix. So we do have some access to electronic health records. We have the one-way portal system that we're using with the University of Iowa hospitals and clinics, sharing information with the embedded pharmacist within those clinics. So we're looking at, how can we do a better job of accessing electronic health records. So those discussions are ongoing. But it doesn't prevent us from getting the information. So we still request it, and we'll get that information. Then what we do is the workup and provide that those interventions and those recommendations as a patient workup, and we keep our track of our own documentation. So we have very rich records, and if someone asks us hey, why did this change and when, we can provide them with that information. So it's just this ongoing thing that we've been doing for the last 13 years in our practice, that we felt very comfortable that when we started doing this pilot, we felt like we already had the systems in place to be successful.
Great. Thank you, Randy. Two more questions. So building on your comment about your own documentation system, can you talk a little bit about your documentation system and your process for creating that?
Yeah, it started literally my first week after I left the university to come on board. And I just realized that the pharmacy management system or the dispensing system is just a record of what you've done in a dispensing mode. There was nothing clinical about it. So my business partner, Mike Denninger, who is also an IT guru, so I was very fortunate in that sense that he was as knowledgeable. I asked him if he could create some kind of a system where we could pull the information from our dispensing system and make it into more of a clinical record. And so he did that, and we've been able to evolve it over time. But literally, it starts off with a profile, and a very cleaned up profile. Medications are color-coded, so we know we are being evaluated on the EQUIP platform from PQA as far as the Medicare Part D plans are concerned. You know, our patients' adherence. So all ACE ARBs are red, statins are green, diabetes medications are blue. So these are the medication classes for which we're being evaluated on, so we can quickly look at those classes of medications that the patients are taking. For those high-risk patients and older patients, those are purple, and the patient's medication record is actually highlighted in purple, so we know it's an older patient who's taken a high-risk medication. So we did a lot of color coordination to make it visual for the pharmacist. But then we have to make sure that we're feeding them information. So we actually will feed them information within our system that will tell them if this patient doesn't seem to be adherent with this medication, so ask them about this. Or if they have duplication of medications, make sure it's appropriate duplication. Or if they have a high-risk medication, you know, can we de-prescribe or work with the prescriber to get them off the medication? So we do provide little notes that just automatically feed in to the pharmacist who's doing the review of the patient at the time. So that's how we've been able to quickly identify the problems, but then also make the interventions that we're doing, so that we're making, again, as I said, 2,000 to 3,000 clinical interventions monthly that's actually documented within that record.
Great, Randy. Last question. You are amazing with answering all these off the cuff. So last one, of the $300 PMPM savings, how much was offset by payments to Towncrest, and did you look at the cost differences in prescription drug prices between the two groups?
Good question. And what I would say is that what they paid Towncrest, which is interesting, it's different than how they're paying the value-based pharmacy program now, which is truly a pay-for-performance. What we initiated when we did the pilot, because they weren't sure what we were going to see, we weren't sure what we were going to see, is we negotiated a professional fee per patient. So that's how we got there. And the savings was much greater, much greater than what we got reimbursed, which is fine, but, you know, hopefully give us a little bit of room afterwards to talk about, well, what else can we do? As we look at what's happening with the value-based pharmacy program right now, and you know, we've had the first year results that have just been put in, they have seen that there may be an increase, because remember I said that one of the most frequent problems that we identified was need for additional therapy. So when you have to add a drug, you do see the drug costs go up, but what you see on the back end is better management of these patients. So you're reducing ED visits and hospitalizations. And so one parameter that they actually looked at was hospitalizations, and the value-based pharmacy program network of 74 pharmacies was able to reduce that between 4 to 5%, so between 4 and 5. And so if we took 4.5%, that was a savings to the payer of about $12 million. So even with the increase in the amount that they had the drug spend, it wasn't even close to the savings that they saw from a reduction in hospitalizations and ED visits.
Excellent. Randy, thank you so much for that speed round of question and answer. We're going to give you a break. And next, we're going to turn it over to Amanda Brummel, Director of Clinical Ambulatory Pharmacy at Fairview Health Services. Amanda?
Hello, good afternoon. I'm going to go right on into the next slide. We're going to talk about our comprehensive medication management services here at Fairview. And much like Randy described, there are a suite of services and care that we may provide our patient populations. And so I'll talk about that a little bit too. But for today, I'm really going to be focusing on our most complex patient population and our most comprehensive service that we provide our patients from a pharmacy standpoint, which is comprehensive medication management. So the objective that I hope to cover with the time that we have is really to help you all realize the value of integrating clinical pharmacists as a part of the patient care team, and how providing those direct patient care services has led to optimizing medication outcomes. And so we'll review some work looking at really that quadruple aim and how we have shown benefit in those areas. So to start, just a little bit of who Fairview is and what do we look like. We're a large integrated health system that is in the Twin Cities area in Minneapolis, St. Paul, Minnesota. So in looking at our care system, I really like to say that we have birth to death. We have, babies being born in our children's hospitals and community hospitals, to a suite of senior housing locations, long-term care facilities, and long-term care hospital, and geriatric and end-of-life care services. So we have around 56 different primary care clinics. We have a variety of specialty clinics as well. We are a partner with the University of Minnesota and have the University of Minnesota Hospital. That's one of the academic health center is one of our hospitals. And we have around 32,000 employees with 2.4 thousand physicians that are aligned and prescribers. So in thinking about that and kind of that structure that we have across our system, we also have a lot of pharmacy services that help support that system. So both on the ambulatory side and in our inpatient settings, we have pharmacists that are integrated across. And again, today we're going to talk really about comprehensive medication management and our pharmacists that work in that area. And so I wanted to take some time to really just spend a few minutes talking about what is CMM. When I say comprehensive medication management, what does that mean? So this is really built upon the philosophy and process of pharmaceutical care, which is a holistic patient care process that looks, again, at a patient and at everything that they have. Their over-the-counter medications, their prescription medications, we're looking very holistically at them. And our pharmacists are doing an assessment, and there's 4 key things that they are going through in that assessment, and that's making sure that every medication is indicated, that it's effective for the patient, so it's helping them to meet their goals, that it's safe for them, and that it's convenient, that the patient can afford it, that they can be adherent to it, and there's no barriers around that. Our pharmacists then may identify medication therapy problems as they're going through that assessment, and they create a plan of care. So they're on average spending about an hour with the patient for the first time when they're going through that whole assessment. And they're, again, looking at their plan of care, they're establishing goals for the patient, and they're looking proactively to prevent any problems that may occur. It doesn't stop there, though, and I think oftentimes pharmacists get brought in to try to do a consult or, see the patient. Can you just take a look at this patient really quickly? And, that's not really what we're providing when we're providing this care. We're really then following up with the patient, and we want to make sure that the interventions that we made and the medication therapy problems that we identified were actually resolved. So we're following up to make sure that we're actually recording what happened with the patient. We're helping them again if something didn't work out right, getting them on track with the new plan of care, and or supporting the plan of care that did work out. And we're doing that in collaboration with all members of the healthcare team. So with one of the things within our practice, we do have collaborative practice agreements, and we look at that by medication class, but if you've translated that into conditions, our pharmacists are able to manage about 15 to 20 different conditions for our patient populations, and they can initiate therapy, they can modify therapy, discontinue therapy, and again, really help to resolve and take care of those medication therapy problems in conjunction as a part of the care team. So when we think about the role of the practitioner, I really talked to you about the service we provide and the patient care model that we have. But I think this really underpins all of that, which is really the philosophy behind all of that. And our practitioners, it's really important and is understood across our practices and providing, again, that consistent approach between all of our sites, that our pharmacists are taking responsibility for those drug-related needs. And they're held accountable for that commitment. And, you know, what does that mean? Again, it's not enough just that they're identifying something. They don't just hand that over to the provider and say, hey, it's your problem now, take care of that. They're really owning that commitment, and they're owning that part of the care for the patient. So they are that equal care team member that's helping, again, to resolve those problems for the patient. And they're really taking that responsibility for medication. So although there's a lot of one-on-one care that happens here, there's a lot of other activities that our pharmacists may do to help support the team from a medication perspective. And I wanted to touch just briefly on fidelity of the practice. And what I mean by that is really that consistency. How can you ensure across your practice sites that this comprehensive medication management practice is going to show the value that you wanted to show and be reproducible? And I spend a lot of time, I've been doing this now for over 20 years, and have built, you know, various practice sites, and we'll get a little bit more into the history here in a bit. But it's very important, and one of the things that was very important for our medical group and our health system is our providers wanted to make sure that if patient was seen in clinic A and another patient was seen in clinic B, that they were getting the same level of care and service. We didn't want things to change based on the practitioner who may be seeing them or the location that they were receiving care. And that really comes down again into that fidelity of the practice and making sure that you're producing something that no matter where you're seeing the patient throughout the system, that it's reliable, it's consistent. And it goes into this wheel really, you know, this triad of circles here. I talked to you a little bit in the last slide about our philosophy of practice, then the consistent patient care process that I outlined with that assessment, care plan, and follow-up. And then there are practice management tools, and a lot of these things go into the results that we want to have, or making sure that, again, that we're providing a consistent product across our quality assurance. So it's really a combination of all of those three, and making sure, again, that that's reliable across the system. That's important. And I say that because we're going to talk a lot about the outcomes that we've had and the work that we've done with our health plans and health systems. And this was a really, again, key piece, because I told you how in our health system we want reliable results. Well, guess who else wants reliable results? Our patients want that, but also our payers want that. They want to be able to know that when we say that we're practicing this, the member is getting those level of services no matter where they are. And so as you expand and as you get bigger within your, you know, your system, or even here in Minnesota, there are many health systems that also employ this type of practice. It's really important from that payer standpoint to know that they're getting the same thing no matter where they're at. And this hasn't always been the case in pharmacy, so I think that's why it's even a bigger key for us. So what's our story? We really started, as I said, I've been here for 20 years, and I was here 20 years ago when we were 5 people. I've been around a long time within this journey at Fairview. And we really started from a small practice site. It was back in 1997 when Fairview and the university partnered. And in that partnership, they were teaching this new practice model and philosophy of practice at the university. And they wanted some sites to be able to have students experience what was called pharmaceutical care at the time, which we now call comprehensive medication management. And so Fairview started those sites, And now we are up to 45 locations across our system. Many of our practice sites, we are in primary care, but we also have practice sites in many of our specialty practices as well. So we're in cystic fibrosis, we're in transplant, oncology, psychiatry. But the main point with that is that we're still providing that comprehensive approach. We're providing that holistic care. So it doesn't really matter the type of practice that we're in. That helps us to determine the patient populations we may focus on. But our pharmacists, again, are providing that view across the whole patient and really bringing that all together for them. So again, this has, as we've grown, and our footprint has grown across our system, within that, it's been very important that we maintain that same philosophy of practice, and our pharmacists now work together even within the comprehensive medication management program, where our primary care pharmacists may be working with our specialty pharmacists as well, and vice versa, as patients transform throughout the system and go through their transitions as well. I often get asked who our target population is with this patient population, and really we are focusing on that most complex set of patients with comprehensive medication management. We offer a variety of services that our pharmacists across our system can interact with patients on. But again, with comprehensive medication management, we're really focusing on that most complex patient population. So oftentimes we're looking at patients who are not meeting their goals of therapy. We might also look at utilization and or prospective risk of that population. And then we're also looking at transitions of care. So I wanted to just spend a little time to think about how we may operationalize this. We actually have alerts that are built into our electronic medical record that can help our care coordinators, for example, as they're seeing some of these higher complex patients, help identify those patients who might benefit from seeing the pharmacist. So we have an algorithm that we've put into place looking again at conditions maybe not at goal, or the hospitalization risk that they may have or have had, and can identify those patients that would benefit from seeing a pharmacist, and a referral can be placed by the care coordinator for that service. In our transitions of care work, we have another algorithm that we have based on what we have found with transitions of care in our highest risk populations. And so that is in our inpatient setting. And so our inpatient teams can be notified if, again, a patient looks like they would benefit from having a pharmacist see them on the outpatient side, and a referral can be placed so that we can make sure that we follow up. So this is important because there are many referrals that we get from the front line from our care teams and, and providers directly referring, but we have also incorporated different electronic ways that we have patients that are identified that need our services as well. So we can make sure that we're looking across all of our populations across the system, and not just in those populations where we have good relationships with a provider and they're making referrals. So earlier I mentioned the quadruple aim, and hopefully this is something that's familiar to all of you. But in looking at this and really thinking about how we make that business case for having pharmacists as a part of the care team and really providing that high level care, I feel it's really important that we focus on the quadruple aim and think about all of those areas and ensure that we are looking at and seeing if we're making an impact in all of those areas. So for us, we wanted to make sure that we were improving patient satisfaction. And in the next slide, I'm going to share some data that we have around our patient satisfaction and making sure that we were hitting the mark with our patients. We wanted to look at our health outcomes. And so we felt it was really important for us to clinically look at the impact that we were making. And I'm going to share some work with our readmissions on what we were able to reduce readmission rates. But we have also done this with A1C control and blood pressure control, looking at populations who may have those conditions, and did we make an impact in those populations. We've looked at this with adherence to see if we're improving adherence rates within our population. So I have some of those additional studies that will be sent out with the slide deck as they come for, this is made available to you. I've added some additional slides there so you can see that information as well. It's really important and to the forefront of many of the care teams now to look at joy in work, not just for our providers, but for all care team members. But we wanted to really look at our providers and see, did they feel like having a pharmacist as a part of their team was helping them with really their health and well-being as they were trying to manage their patient populations? And then last but not least, we wanted to look at total cost of care. Were we making an overall impact in the patient's costs and the health system's costs? And of course, the health plan's costs, so all of those. So this really outlines that quadruple aim, and where we'll spend a little bit of time today just looking at the impact. And I think, again, this is important because as you're trying to make that business case and go back and, you know, feel free to use this data when making your own business case if it helps. I think it's, again, important for us to be able to outline all of that it's not just in one area. We're not just reducing costs if we're not also helping improve quality, for example. So kind of looking at that in that sense. So with patient satisfaction, one of the things that we do is we survey our patients, and we've actually built a survey tool with 9 other health systems that are in our area. We have a collaborative with all of those different health systems, and we created a patient satisfaction survey. And this is published, and you can get this, and if it's helpful for you, you can also request to utilize that same survey. But we wanted to see if our patients felt, one of the questions we asked is if they felt their overall health and well-being had improved because of comprehensive medication management. And we've consistently had results in the 90s. Our most recent was 95% of the patients agreed or strongly agreed. That was one of our published studies with that. Looking at provider feedback, we also do provider surveys, and we want to find out from our providers, you know, are we making, again, that impact, and we want that feedback on how we can work better with them. And of our providers that we surveyed, and we have over 50% response rate. So for those of you that are, you know how hard it can be to sometimes get surveys back, having over 50% of our providers respond to the surveys, great. And of those, we had 95% of the providers were confident in the recommendations the pharmacists were making, and 93% of them felt that the pharmacist allowed them to be more effective and efficient in their practice. With our transitions of care study that we did, this was just published, I guess it's a year ago now in February. We wanted to look at the readmission rates within our patient populations. And those patients who had seen our CMM or MTM, that means the same thing in our health system, our pharmacists, there was a 33% reduction in readmission rates with those patients who had saw the pharmacist versus the same matched group who were eligible to see the pharmacist. But at that system, we weren't, we hadn't rolled that out yet, so that was our control group. We had a reduction in readmission rates, again, across the complexity of that population. And then finally, with regards to costs of care, we showed an average 12-to-1 return on investment, looking at our overall total cost of care with health costs. Now, the big thing to note here is that this wasn't reducing the pharmacy spend. We actually increased the pharmacy spend in our patient populations, but what we reduced was ED visits and hospitalizations. So that's important because, again, that's you know, a lot of times I think if we think in a silo, we're thinking of just, did we make an impact here on the pharmacy side? And that wasn't necessarily the case. So again, kind of coming back to that pyramid and that population approach from pharmacy services, we're kind of circling at the top, but we have pharmacists working in other areas as well. They might be helping in anticoagulation or in specialty therapy management. They're in our community pharmacies, which Randy so eloquently laid out of all the great interventions that can be happening in a community pharmacy. You know, our pharmacies, we have around 35 pharmacies that are connected in our health system too. And those pharmacists are helping manage and take blood pressures. They're looking at depression screenings. They're helping with asthma education and screenings. There's a lot of work that's also being done in our community pharmacies. And then there's a lot of work that's actually just done from a technology standpoint in our clinical decision support and different interventions that we're doing across all of our populations to make our providers more effective when they're actually prescribing medications. So I didn't want to not call that out, just so you can see that lots of things are going on across our system, but the studies that I just shared with you and showed were really all focused on that comprehensive medication management approach. So some things to think about when you're implementing comprehensive medication management. It really goes back to that consistent patient care process and that practice management system. And I know I'm on a little bit of a soapbox with that, but I feel so strongly and have the experience to know that having that consistent patient care process really is meaningful and makes a difference. And you need, if you want to be able to have consistent, reliable results, and you want to be able to have a practice that others can count on, that is truly the cornerstone of this work. The second piece that I would call out is just really understanding your role on the team. And what I mean by that is there are lots of things that pharmacists can do. We are, you know, we're great people and we're highly educated and we always want to help out. So there's lots that we can do. And we have to be careful that we're not doing things that another team member could do that may be more cost effective across our populations. So I'm just going to use the example of, you know, we can do insulin teaching or we could do diabetes teaching, but that might not be the best use of our resources. So it's really understanding our sweet spot with where we really need to be the one that is taking care of the patient in that way. You know, we really are the ones that are helping manage all of those medications. Then that's really our role on the team, and we have to make sure that that's the patient population that we're focusing in on. I talked a little bit about hardwiring those process for referrals, and again, it's important that we make sure we're focusing on the most appropriate populations and hardwiring that process, especially when you want to make that return on investment and you want to make sure that you're making that clinical impact for your business case. It's important that we're focusing on those right populations. And then lastly, measuring your outcomes. And this is really important here too, because again, you can't tell anybody what you did if you didn't measure it. And if you don't think up front about what you want to measure, then we want to make sure, you know, that everything is in place so that at the end you can be successful. Oh. So next, I just want to just briefly wrap up here, and I know we're getting right to the end of time, that I want to just talk a little bit about how you incorporate this into the health plan benefit and really our experience. So again, you've heard this has been a 20-year journey. And when we started this, there were not even any reimbursement codes that pharmacists had that were specific to them that they could be reimbursed for services. This was before Medicare and the Part D program. All right, so it truly has been an evolution. And some of the first avenues that we went from a health plan perspective were to focus directly with employers and make this an employer benefit. And so that's really how we have gotten in had gotten into kind of that payment methodology was to think outside of the box and really take this as a benefit that employers could have for their members or for their employees. And now that's really evolved into a lot of our total cost of care and at-risk contracts, as Randy talked about from his perspective and experience with that. That is really where the payment model is driving. And there's lots of ways that you can look at that and think about that within your own practice. So there are various different payment levers. You may still be somewhat in a fee-for-service world within that, and that's just fine. We have some fee-for-service contracts within our service are getting reimbursed that way. We've worked with our plans. And again, our overall system might be more in an at-risk contract, or someone that you're trying to work with and incorporate as a part of your team might have some risk, and they're still getting a fee-for-service reimbursement around that. But overall, there might be a risk model that's in place around that. Or again, it could just be a straight, like our Medicare or Medicaid program here is just a fee-for-service basis, and they found the value of being able to have these services, and you get reimbursed that way. You may have that mixture between, again, that fee-for-service or at-risk model. So again, as our system has gone out and contracted with the plans on managing our populations as a part of our ACO, we have made sure that pharmacy services are a part of that, and that comprehensive medication management is called out within those contracts. Our health system has really been the pusher and the driver of that in working with the plans, because they've seen the benefit in how we can help manage our populations better by making sure that pharmacists are a part of the team. So again, they can really be an advocate for you within that contracting approach, because they believe in the work that you're doing, and that's part of how we implement our care model here at Fairview, is by having those pharmacists included. So they're included in those contracts as well. We also have just per member per month, right, where we're managing, again, kind of like an ACO population, but we're managing the risk of those populations. And so we have had our services be a part of that PMPM amount, or the plan has paid specifically to have MTM be a part of the care management team and services and give a PMPM amount for that. And that's a per member per month. So there's lots of different levers. I think the most important thing here is to not just think of one way. And I think Randy and I have both hopefully been able to demonstrate that sometimes you just really have to think about things out of the box on how you're going to make that business case, and how you can really take the results that you have, and as long as you're measuring those results and putting forth that effort, that you can move forward creatively to build that business case. And so with that, we'll go, I think, into questions.
Great. Amanda, thank you so much for your presentation. A lot of excellent insights there about CMM and Fairview's experience. We have a few questions. The first is about workforce. What credentialing process do you use for your pharmacists who are conducting CMM? And I'm going to add in there credentialing and training.
Yeah, so there's lots of different definitions of credentialing. And so you can have your health system credentialing, or you can have your payer kind of enrollment in credentialing. For us, I'll speak from the health system standpoint. At Fairview, one of the things that we have done is we actually have a standardized training program, and we've partnered with the University of Minnesota to have that program where we level set in that practice model. So kind of going back to my foundation of how we all have to speak the same language and making sure we're providing that same comprehensive care, all of our pharmacists go through this training module that the university offers, so that we are on the same base with that. Many of our pharmacists are residency trained, but not all of them, because I have pharmacists who've been doing this for over 20 years, and there wasn't a lot of ambulatory residencies at that time. And a lot of our pharmacists are board certified, but we don't require that as well. So it's really kind of coming in and having that consistent training that we go through. And then we do a lot of quality assurance that happens throughout the program as well, where we have peer-to-peer reviews. We also have our payers who, again, are auditing our work and really doing quality assurance for us as well.
Thank you. So what advice, you talked about fee-for-service and the various phases that, you know, pharmacies or health systems could be in. What advice do you have for pharmacists who, say, are at the beginning phases and they're trying to build alternative payment models for CMM?
Yeah, so I think, again, this is sort of a chicken and the egg, right? And it's a hard spot to be in the fact of, what I see if I look at the big picture of this is I don't have a lot of health plans who want to pay for this service unless they can count on this service. They know that it's consistent and reliable and that they have, right, a good product that basically they can bring to the market or the people that they're selling to who tend to be, right, their employers within that. So, you know, I think on our end, what we really need to do is make sure that we're providing that we have a strong product, that we have a consistent model, that we have results that we are able to show them and demonstrate. You know, on the flip side, with that, it's hard sometimes. We want to be able to have, right, receive payment, or we need to be able to receive payment in order to build all of those pieces. And so I think, you know, sometimes it is that leap of faith and being able to take that leap before maybe all of the payment is there, to be able to have that model. And sometimes it comes from conversations, right, within the payer. If they are willing, I've had many payers across the country that come to us and say, we'd love to do this. We don't have the workforce that's doing it. We don't have consistency across that we could actually roll this out across our group. So I think it's trying to find that match from a payer too, who really wants to move into that next level and have something innovative that they are putting as a part of their plan as well, and that they can see the results from and going from there.
Great, thank you. We have a question about the time that it takes to complete a comprehensive medication review. And I'm going to add, and what are your methods? Do you typically do a CMR telephonically or face-to-face?
Yeah, so when we're providing comprehensive medication management, a lot of our visits are face-to-face. So our pharmacists actually hold a schedule within the clinic, and a patient schedules with them much like they would, you know, schedule with their provider. So that time is really set aside for both of them, and our pharmacists are, you know, going on throughout their day with their schedule of patients because they may not be in clinic every day either. So they're not always catching the patient when they're there. They're seeing those patients independently of the rest of the care team. Our pharmacists do spend about an hour with an initial patient, again, going through all of their medications and the documentation and things that go within that visit. On average, they spend about 15 to 30 minutes in follow-up when they see a patient.
Great, thank you. In your experience at Fairview, has CMM been integrated as a value service in primary care practices?
Yep, so again, we're in both primary care and specialty practices, but we've started out, and that's been our foundation, has been in primary care. That's really where our practice developed across our system. And, you know, out of our 45 different sites, about 30 of them plus are in primary care. But then in the last probably, I would say 5 years is when we've moved more into some of our specialty practices, based on really the providers saying that we really want a pharmacist to be a part of the team here too. And as you know, as you're thinking about accountable care and how we're managing our populations, we want to make sure that our patients are, as they're going between primary and specialty, that there's that connection point. but oftentimes in our specialty sites, we want to make sure that someone's comprehensively looking at that whole picture of the patient too, because if that gets missed, that's not good for the patient either.
Great, thank you. So we have a question. When you talk about your most complex patients, folks with behavioral health disorders, how do your interventions align? How are you working as pharmacists to support people with behavioral health disorders?
Yeah, so I mean, patients with behavioral health disorders are everywhere, right? I mean, we have a gradient and a complexity of patients in that area, but we'll take care of behavioral health needs within our primary care sites. And again, we also have behavioral health pharmacists that are a part of this grant that you mentioned earlier that are in some of our specialty sites. And so we are really focusing on the management of their medications. So we're working again with the team to make sure that they're getting the right medications, that there's a reason why they're taking those medications, and that those medications are effective for that patient, that they're safe, they're not having side effects, and they may be doing the management or the in-between management as well in monitoring that, and then helping them to stay adherent. So it might be moving them to a different type of medication, or just making sure that they don't have an access issue and that they're able to afford and receive those medications. So again, really kind of doing that indicated, effective, safe, and convenient approach, and looking at that across all of those medications to make sure that the patient can be successful. And a lot of that also comes into really being able to empower the patient that they can take care of themselves and or communicate when they have needs.
Great, thank you. So last question we have, I'll first pose it to you, Amanda, and then I'll pose it to Randy. Do you have any tips for how you could cultivate provider champions for the work that you all are doing?
Yeah, so I think provider champions are key, and they could have been listed and sometimes are listed in my critical components of implementing a practice. I would say in my experience, my personal experience of finding a provider champion, it's really someone, again, who initially has reached out or is interested, it seems, in the practice or having pharmacists to be a part of the practice. And then it's usually working with them and their patient panel to maybe to start to where they're really now your advocate, right? So they are feeling really comfortable about what you're doing. They understand what you're doing. Maybe they've come to a visit with you, or you've gone into a visit with them, or you've taken the time to see enough of their patients that they can start to see the impacts and the changes that are happening with their patients when the pharmacist is involved in their care. And then they're really going out and doing that job for you. They're advocating, they're telling others, they're helping to really, again, champion you along the way. So I think if you're just placed in a clinic or you're looking to, go into a clinic, it's trying to find that first person who shows that interest and really can sit down. Sometimes I've made the best provider champions by just looking at the patient or the clinic's population and picking out the most complex, or asking somebody who's got the most difficult patients, or what patients are you struggling with that you think a pharmacist could help with, and starting there and really helping to develop that relationship and make them your champion, because again, they're seeing the results that are occurring.
Great, thank you. Randy, same question for you. In your experience as a community pharmacist, how do you cultivate provider champions for this work?
From my perspective, with the work that we have done, it's first identifying those physicians, those prescribers that are actually responding back to you. I mean, because we do have, those situations where we don't get responses back. So we start identifying those practices that are responding to you. Then having an opportunity to develop more a working relationship with them and talking to them about, and as Amanda said, some of the more high-risk patients and how can we work together to better manage patients, what information they need from us, and what can they provide us to help us to do a better job of working up the patient as well too. But from my perspective, I think the way we cultivated it is because, again, it's that trust factor. Because as I look at how working relationships evolve, it's about trust and making sure you follow through with what you say you're going to do, and then making sure you do it, so that there's a trust between the providers, a trust of competence, and a trust that you're actually going to do the things that you say you're going to do. And I think by doing it repeatedly and building on that relationship, I think that's how you build these physician champions for your practice.
Well, on that note, just want to say a huge thanks to Randy and Amanda for sharing all this excellent information, your insights, all the questions that you fielded, to all the participants for posing all these great questions, and of course to the Gordon and Betty Moore Foundation for your support of this initiative. We are presenting on this final slide here a few relevant resources that you can find if you clicked, as well as on the chcs.org website. Please, folks, it would be really helpful to us if you could complete the webinar evaluation that will be sent. And the webinar slides and recording will be available on chcs.org and will also be sent to you on Monday. So thanks again for tuning in, and visit chcs.org to learn more. Have a good day. Bye.